Health Equity Matters. I'm Elgloria Harrison, the Dean of the School of Health Science, Human Services, and Nursing. Today, I'm thrilled to launch this podcast on health topics that matter to our community with a special focus on equity. Today, we're diving into hypertension and why this is called the silent killer and what this means for our community. Did you know that approximately 33 to 36% of the Bronx adults have high blood pressure? I did not know that. And that estimate of 363 individuals. So the Bronx have the highest number of people diagnosed with high blood pressure in New York City. To help us to dive into today's topic, I am joined by Dr. Sheila Hankin, Assistant Professor in Nursing, and Dr. Kimberly Souffront, Associate Professor of Emergency Medicine at Icahn School of Medicine. I pronounced that wrong.
No, that's right.
Welcome to this episode of Your Health Equity Matters. Dr. Sheila Hankin has been a family nurse practitioner since 2000 and a registered nurse for more than 30 years with a keen interest in hypertension and health equity research in the Black and Latino community. Dr. Kimberly Souffront has been a registered nurse since 2001, a family nurse practitioner since 2005, and in addition to being an associate professor in emergency medicine, she's also an associate director of the Center for Nursing Research and Innovation, and her research interests include hypertension and health disparities. We're so pleased that you're here as our trusted voices in the community. Thank you, folks, for being a part of this episode. I'm excited to hear your insights. Let's start talking about what is hypertension and why is it called the silent killer? Who wants to take that on?
Good afternoon. So the high blood pressure or hypertension is referred to as the silent killer because often there are no symptoms displayed. And you can go a long time without the symptoms, so without being detected or diagnosed with hypertension.
And so tell us, why is that so important? Why does that matter? I mean, we have high blood pressure. Well, what is actually high blood pressure? How does that work, actually?
So the way I describe it to patients, it's the force of blood against your blood vessels, right? And if you think of your blood vessel like a hose, right? If the pressure is too high in that hose, eventually it will affect the entire system. And that entire system is your mom, your dad. It could be your kidneys, your heart, your brain, right? And so that's why it matters, because it's not just you. It's the whole system. It affects everybody. Over time, high blood pressure, like you said, Dr. Hankin, you don't feel it. And because you don't feel it, you don't get checked. Right? The majority of high blood pressure cases are not diagnosed in the primary care office. They're diagnosed in your obstetrician, your GYN, or the emergency department where I work.
Okay.
Because you don't have symptoms.
Okay. So when I go to the doctor and they take my blood pressure, that's when they're supposed to tell me, though, that I have high blood pressure, right? And they have told me that I have high blood pressure.
Well, of course. I mean, 60% of the country, 60% of Black folks in the country have high blood pressure. So
Right.
But the amazing part of that is when we ask people what high blood pressure is, they say they've heard of it, but they don't really understand it.
Right.
So maybe, I think one study said that 74% knew what it was. But of that 74%, 40% said they had high blood pressure. The ones who didn't say they had high blood pressure actually did.
Wow.
The ones who said they had high blood pressure were treated, but they were uncontrolled.
Okay. So there's a difference, So you can have high blood pressure, but it has to be controlled, and typically controlled by medicine, I suppose, right?
Medicine is one tool.
Okay.
But there's
many other.
Yeah, they, what we call the
Lifestyle modification.
Simple 8, right? So there's the lifestyle modification, no smoking, and a number of diet and lifestyle modification that you can engage in, but medication for the most part if it's not caught early, most people are on medication.
Okay. So let's just start back. So if indeed we're diagnosed with high blood pressure, how does it affect other parts of your body? Is that why we should be worried about hypertension?
Yes, high blood pressure is so closely related. One of the risk factors for cardiovascular disease.
Oh, okay.
So in terms of looking at heart attacks,
Okay.
strokes,
Okay.
problems with your kidneys,
Okay.
your eyes. It
Okay.
affects the arteries in the brain, dementia.
Oh, okay.
So it can affect so many different parts of your body.
Okay.
So we really need to check it. And most people go undiagnosed for long periods of time. So when they are diagnosed, they're at an advanced stage why the medication is needed.
Oh, okay. Okay.
You can imagine how hard my job is, right? Telling somebody they have high blood pressure in the emergency department when they're there for a laceration, right? So the way you communicate to your patients when they're already at a higher, state of stress, right? Being in the emergency department is hard. Some of the work that my team did, we just a year ago, we recruited a lot of patients with asymptomatic hypertension in the emergency department. And what we found was that 100% of them had subclinical heart disease. 100% of them were on the trajectory for heart failure and didn't know it.
Wow.
Right? And so that's the community that we see in the emergency department where you're there for one thing, right? But we're catching uncontrolled hypertension that they've had for years, right? And so the myth or the conversation is that it's pain, it's anxiety, it's the chaos of the visit. It's not. It's chronic uncontrolled hypertension, and that's the opportune time to catch them. That's my lens, being in the emergency department.
Absolutely. I mean, that's actually a good lens because a lot of patients wind up in the
Using
emergency,
the ER as their primary care.
using the ER as a primary
And they're there,
care.
and for the majority of the time, they're not getting primary care. They're there for episodic issues, right? They're there for whatever the issue is. But the reality is that that's an opportune time. It's a missed opportunity. They have, time to identify it and communicate that risk. And so what we do now is a recent study I did was using visual storytelling, visual storyboard, showing them someone that looks like them in the emergency department that it's, there's like a narrator, that it's not pain or so forth, that it's, your heart muscle stretching and so forth. But it was a really successful, great study. Hope to scale it.
Yes, I've read your study, and a lot of times what happens is individuals go to their primary care physicians, and he may even say it to them, but they don't ask any questions. I do a lot of work in the community, and the focus there is really for them to know their numbers and know what this means.
And what are those numbers? Tell me, what are those numbers? I know that they've been changing.
Yeah.
What are those numbers, though?
Now, so the SPRINT trial was a very large trial, about 2017. It basically was a really big national study funded by the NIH to understand how low can we go, right? Because the tradition was that it was 140, less than 140 over 90. That was your goal. Anything above
Then it was 120 over 80.
Right.
Now it's even.
Yeah, so that was a very large study, and it found that blood pressure less than 120 over 80 is, they had less heart attacks, less strokes, they lived longer. There was a lot of, positive outcomes. And so that's why those guidelines were changed.
Wow,
Yeah.
they were changed, yeah. Because I remember when I was in school, it was 120.
Oh, man.
That's you.
How low can you go?
I turned
We
mine
cannot
off.
go very much lower than
It's to get my
119.
kid so I don't forget her, because I've done that before.
Like Dawn. Also what happens, even if they go to a physician, say, I went to Mount Sinai to a specialist to have a stress test.
Uh-huh.
My pressure was 210 over 110.
Come on.
Yes.
Don't tell me this.
So she should have done something.
Were you symptomatic?
No, of course not. And she sent me on my way. The
person
test was fine. and she sent me on my way.
Oh, this was a primary or?
No, it was a specialist.
Oh, okay. Yeah.
But
That's-
that if, as a healthcare provider, I see a pressure like that, I'm not sending you home.
Wow. I know that I teach a class here and there, and we do health fairs, go out into the community. And I remember when I would go out into the community and we would do blood pressure screenings for older adults, younger kids, or just regular adults, and sometimes the blood pressure on the monitor. Now, sometimes our little monitors that we buy are not
Right, are not the
necessarily
best.
validated and things like
Yeah.
that. So but what we do see is when and we take the blood pressure a couple of times. We've been taught. You take it a couple, you see it's
Yes.
abnormal. You take it again, right? Just to be sure that you did
Yeah.
put the cuff on right and all this kind of carrying on. But when we see it the second time, then we have to say to the person, look, I can't diagnose you with high blood pressure, but what I can tell you is that you probably need to go see your primary doctor. Or what I have done is said, have someone told you that you had high blood pressure? And if they said, oh yes, they've told me that. Okay, are you on medication, or what are you doing to kind of help to kind of arrest your high blood pressure? So if they are knowledgeable about their own condition, then I felt like, okay, so I wasn't overreacting or any of those kinds of things. So that was really some of the things that we have to do. We do believe those screenings become very important. I remember when I was out on Boston Road and we did a health fair for a lot of older adults. They were very interested in understanding their numbers. They were very interested in that. But it's sometimes with those health fairs, it's limited of what we can actually do, except for tell them, go see your doctor. And maybe some of them have seen their doctors and just have not followed through. So tell me, why wouldn't people follow through? What stops them from, I know that some of my older patients just don't want to take medication. I'm perhaps going to be in that category at one point. Older patient don't want to take medication. I said to my doctor early on, like, I only want three pills. Whatever you do,
I'll give you the 3-in-1.
I just need 3 of them. All that, so you can't add a 4th one. You have to take away 1 because I have to remain at 3. Anyway, that was just kind of my, kind of humor with my physician. But I mean, I do keep up with all the things that I need to keep up with. But I personally don't want to have to take a lot of medication. I see a lot of people come to the emergency room with bags of medication. And you don't know whether or not some of these medications are interacting with each other. And so sometimes I think that, before I get off on a tangent about medication and things like that, let's bring us back to why is it that we, African Americans, are subject to so much high blood pressure? Is there something in our genes that is I just don't know. And I think maybe a lot of
your genes.
Maybe many of our audience want to, really understand why is it that they talk about Black people with high blood pressure all the time?
And we do, Black women, Black men have the highest rates of hypertension.
Yeah.
And so my dissertation study was just on that subject. Mm-hmm. And so much contributes to that. And in recent years, for decades, they've been looking at this, but the impact of environmental determinants on high blood pressure and the stress levels, the conditions under which they're living. It's not just about not having access. It's food deserts. It's living in overcrowded buildings. It is all very stressful, and it all builds up those cortisol levels and your reactions.
Your zip code is more predictive of your health outcomes than your genetic code. So it's not your genes. It's not the genetics. It's not your DNA. It is the community that you grew up in. It is the lifestyle that you learned, right? How you cook your food, right? It is the structural barriers that, around you, right? How do you get to your doctor or nurse practitioner,
Right.
right? Do you have to walk blocks to a bus? Can you afford the bus? Can you? All right. It's very easy to hand somebody a prescription, but that's only 25%, right, of your
Right.
health outcomes,
Right.
right?
You know,
The
even if they
clinical
get the
care.
prescription, if there's nowhere to fill it, if there's no
Right.
resources, funding
Right.
Right.
It's all those
to help
drivers.
them,
Right.
be adherent with the regimen that you may prescribe.
All right. So let's say this again. It's not your genes, but it could be your zip code.
It is your
could. It
It
is
is.
your zip
It
code.
is.
All right, we want to get that right here. It's not your genes. So don't think that it's your genes now.
not
It
with
is-
hypertension. I
Right.
don't know about
Other
chronic.
things, right? But for hypertension, so it is. So the zip code has a lot to do. Very, very much has a lot to do with how. What would you say to our audience today? What could they do right now to kind of help themselves? What could they do?
Some of the standard things. Lose weight.
Lose weight. Okay, she's talking directly to me. I think.
No, I'm not.
And we call them standard, but they're they're
But I mean,
hard.
the diet is really very important. I've heard people say, I use sea salt or I use kosher salt. No, the content of the salt is the same.
Salt to salt.
It's right. It's the same.
Pink salt, white salt, salt to salt.
You can't live a sedentary lifestyle. You got to be moving.
Right. Right. Right.
Just things that they really know. And even if you encourage them to do these things with a buddy, just so they get out and do it.
Right, right. Is it important for us to understand that when we're old, as we get older? Is that even more important?
Yeah. You mean, more important to control blood pressure?
Right.
Absolutely. Absolutely. I mean, by the time you're 65, 70, probably like 90% of most people will have high blood pressure.
Right.
That's okay. It's okay. But there's things to control it. As long as you manage it and keep it well controlled, the risk for kidney, like heart failure, stroke, retinopathy, like all the chronic burden is relieved when your blood pressure is controlled.
But it's
But you
also, as the aging process goes, I've seen people slow down. They know they should be moving. They know they should be eating a specific type of diet. No, it's easier to grab something on the way in.
Right, right, right.
And so lifestyle just slows down for them.
And then you have other chronic conditions that occur as you age, right? And then hypertension exacerbates
It's all of those
all of
conditions.
that. So that's why it's really important to keep it well controlled.
So I just want to go back and just kind of reiterate for our audience. It's not just about hypertension, but it's what hypertension can do for the rest of the body. So it is a precursor for heart disease. And so
Definitely.
we want to make sure that everyone understands why it is considered the silent killer, because there are just no symptoms. But if you don't actually understand that, it really was going to impact your health. It will impact your heart. It'll impact your kidneys, all the things that really keep the body kind of going. Is that a fair assessment of?
That is.
Right. So we want to make sure that what things might you say, Dr. Souffront, for the people that you see or the patients that you see, Dr. Hankin, for the patients that you see, what do you tell those patients? What should they be doing? Besides, I know we've just talked a lot about changing the lifestyle. Anything else that might, that they might consider is having conversations about hypertension. Is that helpful?
Yeah, normalizing it.
Okay.
It's not a, I don't have that, or,
Okay.
it's okay to take a medication.
Okay.
Because
It's a
what
tool.
happens is the labeling, affects their mental state.
Right.
So then they don't want to, it's not like a stigma, but it is. No, I don't have that. I don't have that. I'm good.
Okay. Okay. So we really want to destigmatize all of these conditions that really impact our community, because we really want them to be healthy. we want them to recognize that there are things that they can do to kind of help themselves. Is that right?
Yes.
And I think that if indeed we are actually kind of, as trusted voices, we reiterate that it's okay to have these conditions. It's okay. What's not okay is to deny these things and to not go and seek help or seek treatment. What might you tell, I know that you guys are, you educate the next generation of nurses. How do you tell your nursing students what to tell patients? How does that work?
The same thing I would tell my patients, I tell my students to tell.
Right.
That, expect what they're going to say. They're going to say, in the context of emergency care, they're going to say, oh, I'm fine. This emergency department's crazy. Oh, I'm fine. I'm in a lot of pain. Oh, right? So expect that and know your comeback, right? And the comeback is, you are absolutely right. Pain can increase the blood pressure, but the blood pressure will go down, right? So we've managed your pain now. Your blood pressure is still very high, right? And then you can kind of talk about the complications of high blood pressure. But it's just very challenging in the context of emergency care. They're not there for that. They're not there for that.
But in the community, seeing patients, they have certain barriers, and certainly some of the barriers are simply knowledge, adherence. They may start taking the medication. No, it sort of upset my stomach. I just didn't feel right, so they don't continue.
Oh, okay.
There are barriers between patients and healthcare providers. So, whether it's history, what they've heard, they may not really be listening. I'm here because I need my medication. I don't want to hear what you really have to say. So they're not really taking it all in, accepting what you have to offer. And again, the system itself is a barrier to get the care that they need. It's difficult for many people.
Oh, okay.
It's difficult. I have good insurance to get an appointment. So for others who may not have the same resources,
Right.
I understand what they're going through.
When I first came to New York, which is now 6 years ago, that was a very interesting thing. I would be able to call my doctor where I came from, and I could get into an appointment the next day. I came here, the appointment was not the next day. Oh, well, we can get you in next week sometimes, or next month
Next month
sometimes.
is
Especially if
more
it's a
like it.
specialist. If it's a
After
specialist.
yes.
It's more like it.
It was very interesting that I wasn't able to just kind of go into the doctor's office like in the next day or two to be seen and things like that. Some of it has a lot to do with just the sheer numbers of people that I guess are getting to be seen and things like that. But I think you bring that as a good point, that even if we have all of the tools that we understand about how to take care of ourselves, the system it doesn't help us either.
It doesn't
though.
help, yes.
Right, the system. And so therefore they wind up at the emergency room.
Seeing you.
Yeah, so because that's the quickest person that they can come and see for something that is non-related or something that should actually be handled by their primary doctor. One of the things that I also believe that many of our people in our communities don't have a primary care doctor, even if they have some semblance of insurance. They don't have the ability to just be able to say take off from work to go and see a primary care physician, which may only see someone from 9 to 5 or 9 to 6, and therefore that becomes a barrier even more so. So, high blood pressure. It's one of the things that we talk about because there are so many of us that actually have high blood pressure. So it's very important. But it's not just so much about high blood pressure, but it's about high blood pressure and how it impacts the rest of our body. And so if we want to remain healthy, we really have to consider that as well. High blood pressure can be controlled with proper diet and exercise and adherence to your healthcare providers' recommendation for medication use. Learning to help yourself assures you can continue to help your families and your community. I want to thank my guests, Dr. Sheila Hankin and Dr. Kimberly Souffront, for sharing their insights and expertise. Thank you for joining us on this episode of Your Health Equity Matters. Next time, we will talk about informed care, trauma-informed care. Till then, stay healthy, stay informed, and see you next time. And remember, if there's something that's burning that we didn't cover today, please drop it in the chat and we will actually get back to you. Thank you so much.